The last talk of this session will be about headache and facial pain for ophthalmologists, given by Dr. Shafez. We have 15 minutes, Dr. Shafez, for this talk.
Okay. Well, you know, for the ophthalmologist, a headache is a chance to give yourself a headache for a moment as you listen to a patient tell you about head and ocular pain, because you're saying to yourself, what am I going to do with this patient? But it is really an opportunity to do something very positive for a patient. People get headaches a lot, and this is a very cute cartoon from Gary Larson, and it's the one duck is saying to the other duck, oh God, George, stop the car, I've got another migration headache. So neurologists do this all the time with headaches. We listen to the patient, we try to take a history, we observe the affect of the patient as they're telling us about pain, we ask them when the pain started, where is it worse, how is it changing, and how often does it happen. How bad is the pain, and what's the pain like? And people have trouble describing pain. They'll say it's either throbbing, it's sharp, it's boring, it's a band presentation. Is there anything with the pain that happens? Are there any other symptoms? Is the pain changing? Is it getting worse, better? What makes it better? Rest or medication? And what makes it worse? And how much worse does it get? Is it worse in the morning or in the night? When we look at pain and with a red eye, I'm not going to cover any of these things that routinely ophthalmology sees. Certainly the two red eye problems that we as neuro-ophthalmologists worry about is orbital pseudotumor cellulitis, and this patient just had a little faint erythema here associated with an orbital myositis. And we look for a red eye with the Horner's. Now this is a chronic Horner's, and it's a white eye. And so this is less acute in its concern, but a Horner's with a red eye means acutely that day you do an MRA or a CTA and look at that carotid in the neck to rule out an aneurysm. A white painful eye with a headache is a little bit different. And in this, we're thinking first of eye strain or any of the problems associated with the trigeminal nerve as it goes to the structures around the eye and to the eye that could be sending pain from any place in the trigeminal to its origin on the eye itself, or problems in the brain that again pass along the trigeminal and give you pain in the eye. Eye strain, we all know about. Patients use their eyes and they have more of a headache. If this will be worse in the afternoon with eye use, it's better on the weekend or when they're not using their eyes. So that's not an issue. Somewhat more of an issue is pain associated with intracranial structures, whether in the dura, along the structure of the brain. That is all innervated by V1 when we look at the surface of the brain and on the falx, and it's V2 associated with some of the base, especially along the sphenoid ring and mid part of the intracranial fossa. So that pain again can be referred to the local places in the face related to those structures. Just as right upper quadrant pain in the gallbladder can be associated with the shoulder, so too you can get referred pain to the eye. So as you listen, you must think of what else it could be. So we've covered some of this. This is just reminding us of V1, V2, and V3 associated with those nerves as they pass through to the eye. My techs do a great headache history for me because I don't want to sit and have to do this. I may want to check them, but I don't want to have to go through every detail. And they'll come out and they'll tell me what it is. So if they can tell us what it is, so we too as ophthalmologists can make that decision. And we can differentiate pain from the sinuses or the teeth, or the TM joint, or the brain, cervical problems from other problems. And we remember that sphenoid sinus problems can be referred to the frontal area or to the vertex, and patients that dive into cold water will get a headache from just the trigeminal stimulation that they can get. So non-referred pain, non-ocular referred pain is common. Acute sinusitis is big. I've only seen one patient in my career that had acute frontal sinusitis that presented to me with eye pain. She did not have much else that was significant in her external exam, but for some reason I just happened to palpate her lid margin, and it doesn't hurt for ophthalmologists to remember again where the ostia is along the lid margin, and if you feel the mid-upper brow, you'll feel a little indentation, and that's where the frontal nerve comes out from the frontal sinus. And if you have a patient who's telling you they've got a lot of pain right here and it's really severe and acute in onset, you can make the diagnosis in the chair if you just feel along the lid margin and feel that ostia. And if it's always a little tiny bit tender because it's a nerve, but if they jump out of the chair, you have frontal sinusitis. I don't think transilluminating the frontal sinus is very helpful, but the books tell us we should do it. Muscle contraction headache is that headache that we see a lot, and that's that dull pressure ache that patients will tell you it's like a band, it's like a vice that goes around my head, and it really relates to the muscles and their insertions, frontal, temporalis, and occipital cervical areas in a band, going down into the neck as well. And so if you palpate those muscles, you will notice that they are tender, and patients will tell you that with massage or with local pressure or with heat to rest the muscle, they are better. So what the next thing that you want to do is say, well, is this muscle headache due to a neck problem or something else? And certainly the neck problems will be associated with shoulder problems, and if you palpate the shoulder, they will tell you that it hurts. I can't tell you how many patients come into me as a neuro-ophthalmologist for eye pain and headache that have cervical strain. And I don't know if other people have the same situation happen, but it certainly happens a lot for me. What they're worried about is the fact that their eye hurts, and they've kind of ignored the shoulder problem for a long time. These will be worse in the afternoon and the evening more as people turn their necks, and really better with local care. TMJ is the big one, though, that you have to know. And TMJ is better called today myofascial jaw dysfunction. And the patients have painful temporalis muscles. And if you feel the temporalis muscle in your temporalis fossa, and you open and close your mouth, you can feel that muscle contract. And in fact, patients will tell you that the pain is worse with clenching, chewing, or when they open their mouth very wide. So what about non-ocular referred pain? Well, trigeminal neuralgia is the big one. And trigeminal neuralgia is going to be more common in people that are over 40. It's commonly V1, so it comes into us, but it's a neuralgia pain. It's not that dull aching pain. This is a sharp electric sensation, and it follows the dermatome innervation of V1 to the eye. And patients will have spots along V1 where they can be especially tender, and where touching will bring on the pain. We treat trigeminal neuralgia to start with Tegretol or long-acting Tegretol with quite good results. For it to be trigeminal neuralgia, it must be associated with normal pin and light touch in V1. Otherwise, it's trigeminal neuropathy, and something's pressing on the nerve that you have to know. And any pain, any irritation along the dura is going to give you V1 or V2 pain. This is a patient with a arachnoid cyst who came in with headaches and had referred pain to the face and to the eye. So any meningeal problem can do it. Pituitary apoplexy, sphenoid sinusitis, or even hypertension will give you referred pain to the eye from meningeal irritation. Retrobulbar neuritis we're used to with pain on eye movement. That's not a surprise. We will talk about Tolosa Hunt and brain tumors as well. The key with your brain tumor headache is the headache's always on one side. Any local mass, brain tumor, aneurysm, AVM, the mass is really on one side and the pain is much more there. Because there's a local mass, the pain is worse in the morning, and it's worse with Valsalva. So those things coming out as worsening the headache in history have to make you sit back and worry. The interesting thing with brain tumor headaches is the pain isn't usually very bad. This is a dull aching pain and is often relieved by Tylenol and aspirin. I rather like this paper by Kathleen DeGray in Headache last year, and it was talking about IIH without papilledema. And when you look at IIH without papilledema and compare it to IIH with papilledema, there really was not much of a difference in the headaches. The headaches were unilateral, bilateral, often that kind of pulsing headache that patients with pseudotumor will get. So there was not much of a differentiation. So what we have to remember as we listen to some of these patients that have headache that we can't just characterize is be sure that you're not dealing with IAH without papilledema. I think all of us have had surprises in our clinic when eventually we followed these patients with headache long enough and decided that we should really try to check an LP to be sure that they don't have intracranial pressure increased, and found that they do. That vascular headaches that give us referred pain to the eye include hypertension, migraine, AVN aneurysm, and giant cell arteritis. So a throbbing pain is a vascular headache, and these are the ones that we should think about. The key to your vascular headache that's hypertensive is that it's worse in the morning. And if you put pressure over the hypertensive vascular headache, over the superficial temporal artery, that artery may be tender to touch initially, but as you press, the headache gets better because you're decreasing the volume of blood going through the superficial temporal artery. It's very interesting if it happens. AVM, vascular headache that's on one side, and we can see it like that before they come in with seizures, neurological deficits, or hallucinations. So your AM headache, hypertension, increased intracranial pressure, arthritis from sleeping on a bad pillow, and TMJ from grinding your teeth at night. So headache worse in the morning, these are the four things that pop into your mind, and you have to go through that differential right away with them. What about migraine? Well, migraine is another vascular headache, and these patients will have a throbbing headache or a muscle contraction type headache. They get autonomic problems with a pallid skin, often a little GI upset, and depression is genetically linked to migraine. They are characterized as a sick headache, but the key to the migraine headache is that it alternates sides. It's very uncommon for migraine not to, and so it really should be an alternating headache. And these patients will be light sensitive, sometimes sound sensitive, and depressed and irritable with GI symptoms when they get their headache. Migraine is, again, an alternating hemicrania, and this is from Egyptian hieroglyphics, and this was a patient with a migraine headache, and these are two half sides of the brain, and a hammer, and the vascular quality and throbbing quality to the headache. The aura that happens with migraine is up to 20 minutes, and it should not be longer than that, and it's really a visual aura. This was another example of children drawing what their headaches were like that were migraine, and I think they're rather fun, and they show us, again, the throbbing quality, hit with a baseball bat or a hammer, and a hammer inside my head. You know what? When I listen to patients tell me about an aura, I want them to tell me that if that aura, if it's migraine, is really 20 minutes, and the aura should be starting somewhat near the center and progressing out steadily through the occipital cortex, and it should take about 20 minutes. Physiologically, that's what happens in migraine. If patients tell me that the aura lasted a lot longer, I'm not going down the migraine road. I'm looking for vascular problems in the neck that could be associated with this, a local mass that could be associated with it, because it's something else. They can be either negative scotomas, or they can be positive hallucinations that progress out. Well, what makes headache worse? Migraine headaches will be worsened by any of these agents, by smelly cheese, Chinese food, MSG, chocolate, citrus foods, perfume, hot dogs. Even though it's a genetic predisposition, we get exposed to these things earlier in life, and so most patients with migraine headaches will have their headaches start when they're young, in the first few decades of life. It's uncommon for migraine to happen late in life as its first headache. It does happen, but it's uncommon, so we always think a little bit more about late life migraine. Sometimes these patients don't have as much of a headache, and if you think, if you have a patient presenting later in life with what looks like migraine, you really have to think about other things. Check and be sure that they're not taking any oral contraceptives, because migraneurs with auras that take oral contraceptives get strokes. And so you've got to ask about that. Patients do not tell you that they're taking oral contraceptives necessarily. They think of that as something regular, like a vitamin almost. And so they often don't list it in their medication schedule. So you've got to go back and ask, are you taking oral contraceptives? Well, yes. And so please be sure that you refine that, because that's very important. Okay, I'm going to just finish with cluster, because cluster is a headache that happens in a cluster or increased frequency over several weeks. The headache just doesn't go away, and it is localized to one side, often with redness and tearing on one side, a sense of lacrimal congestion, and with the Horner syndrome as part of the vascular phenomenon that happens with cluster. Cluster is somewhat more common in young men, and cluster is thought to be associated, to be worse at night, and associated with alcohol use, and patients with cluster will walk around holding the side of their head and not able to lay down and rest the way typical migraine patients do. And what you must rule out when you think you have a patient with cluster is be sure that that Horner syndrome is not associated with any underlying vascular problem, as Andy mentioned, like a dissecting aneurysm in the neck. And we're not surprised if an older patient comes in, perhaps with an aneurysm in a dissecting aneurysm in the neck. But young patients get them as well, whether it be from chiropractic manipulation or a sports injury. So be sure you think of it, because it will be life-saving. And I just want to finish with reminding you that there is that the diagnostic workup for headache should be done if any of these red flags show, and the red flags are acute onset, unusually severe headache, increased by Valsalva, position or change in headache, late age and onset should make you always think. Headache that's getting worse, even despite migraine medication or pain medication. Certainly any focal neurological sign or symptom would make us jump in, and anything fever or systemic associated with the headaches would make us want to jump in, put that in context, and evaluate it. Thank you.